So welcome back, everyone. I hope you are enjoying your lunch. It is my pleasure to introduce our keynote speaker, Dr. Wendy Ellis. Dr. Ellis is an assistant professor in global health and the director for the Center for Community Resilience at the Milken Institute School of Public Health at George Washington University. The Center for Community Resilience seeks to improve the health of communities by enabling cross-sectoral partners to align policy, program, and practice to address adverse childhood experiences in the context of adverse community environments, or as Dr. Ellis has coined it, the pair of ACEs. The innovative framing of ACEs with an explicit focus on equity and prevention has had a substantial influence locally, nationally, and internationally. Dr. Ellis holds a Doctor of Public Health from George Washington University, a Master of Public Health from the University of Washington, and a Bachelor of Science from Seattle University. Dr. Ellis is a frequent consultant, lecturer, and author on topics of buffers and supports as important pillars in building personal resilience. Additionally, Dr. Ellis serves on the National Academy of Medicine Culture of Health Committee to address health equity, chairs the Golf Research Project Committee of the National Academies of Science, and in 2020 was appointed to the Board of Scientific Counselors for the National Center for Injury Prevention and Control of the Centers for Disease Control and Prevention. Everyone, please join me in welcoming Dr. Wendy Ellis.
So I have to admit, despite all of those titles or what have you, I don't know what's more nerve-wracking, defending your dissertation in front of a bunch of academic skeptics or presenting your work in front of a room full of judges. So you all help me out here. I noticed on the agenda that my speech is under ethics, which I hadn't really thought of it quite that way. But I think is important, because ultimately what we're talking about is what is our ethical obligation to the communities that we serve? And more importantly, what do we owe our children when we talk about resilience, when we talk about adversity? And so I do appreciate that framing, although no one has ever framed my work quite that way around ethics. But I do think that ultimately, that are the hard questions that we have to ask ourselves about the outcomes that we see and the opportunities that we have in front of us to address them. So before I get started, I do want to do a level set around that word resilience, because it has been used, and I will say misused and misappropriated, from one that is a term in physics that refers to an object's ability to bounce back after suffering impact. I don't think that's what we want to apply to the human spirit when we talk about resilience. Instead, perhaps we should think about resilience in the sense of, yes, from a public health perspective, we do want individuals to bounce back after suffering traumas, abuse, adversity. But we also, from a public health perspective, want to make sure that not only can they bounce back, but we're preventing that trauma, that adversity, that impact in the first place. And additionally, recognizing that not everyone will be bouncing back to the same position, meaning that some are more vulnerable to adversity and trauma than others. And so really, when we think about resilience, what we're talking about is at the community level. What are we putting in place so that we are both preventing and treating, but more importantly, helping individuals bounce forward and thriving? And so that's the framing that we use in our work at the Center for Community Resilience and with our partners from across the country, some of them here in Texas, to think through that public health thinking and lens is how are we both preventing, how are we also helping communities to thrive and to bounce forward? It is a dual task, but I challenge you as judges particularly, we can walk and chew gum at the same time. So I am going to talk to you today about the pair of ACEs, this graphic that I created in desperation, quite frankly. I had to do a presentation about 5 years ago to a group that had never even been exposed to ACEs, and trying to understand and distill the science of adverse childhood experiences, the science of social determinants, to really make it a call to action. And hence came that little tree. And so we'll talk about that for a bit. But then I also want to challenge us to examine, to go beneath the soil of that tree, to understand the policies and the systems that drive the outcomes, many times of which you see in front of you in your courtrooms, that contribute to mental health issues. And then learn to use the local data to help inform access and community engagement. And that in community engagement is so important from both a buffering perspective of helping individuals and communities bounce forward, but also the prevention piece of this. So just to give you a little background on what we do at the Center for Community Resilience in Washington, D.C., it is a national network of collaboratives, of community organizations, backbone entities such as children's hospitals, local public health departments, we have judiciaries that are involved, we also have social services, and grassroots community groups, as well as parent groups, educators, that come together to really coalesce around defining what is the pair of ACEs in their community and how can they come together to address these issues. Through this work, we have come to understand that inequity, whether that is urban versus rural, whether that is Black versus white, whether that is income versus low income, we have to be able to willingly be able to look at what are the drivers of inequity as it is relevant to that community. And so our work, our deep dive work in communities that are very diverse, has helped us create tools on how to lean into these very difficult conversations and sit and hold space for that. Not blaming, not shaming, but understanding, seeking understanding, coming in with a lens of curiosity. And that has actually strengthened the work that we do with local public health departments, understanding that local public health has really been challenged, not just because of COVID-19, obviously, but even before then, of being charged with being the guardians of public health and yet being under-resourced, underfunded to do such a dynamic job. And so how do we as community members come together to work with public health in the interest of our public health, our collective health, and putting that in the driver's seat of actually pulling together multiple sectors? Because at the end of the day, that really is the mission of public health, to work across sectors. And I noticed in your book here, you recognize that as such, even in the graphic that's in the front. Although public health is listed as a column at the beginning, in the reading of it, it shows that public health, or it illustrates that public health really should be a wraparound. And so if there's a graphic artist that wants to work with our team to actually redo that graphic so that we can show that public health is really intertwined and across all of those sectors, we're more than happy to help. Most importantly of our work that we do is taking the real-time lessons learned from communities and influencing policy, informing policy, but also using community voice as the advocates, not just those of us with these letters behind our names and expertise, but the wisdom of the community to help inform policy, and also stepping aside and sharing power so that that community voice can be heard. This is just to give you an idea of the geographic distribution of our sites. Some of these are the BCR networks, some of these are the local public health departments. We are also adding 5 more local public health departments to the network, which will be announced in 2 weeks, that also cover urban, rural, red, blue, and unfortunately, in the time that we're in, public health has become extremely politicized. And so it's important that we're able to do this work regardless of your political affiliation, because at the end of the day, health is not political. Health is something that we're all either born with, a capability to have good health, to access the things that we need to be productive and healthy. And that has nothing to do with who might be in Congress or who might be in the White House. So let's talk about this process, the building community resilience process. And I think this is a really important lesson for, regardless of what it is that you're trying to achieve in your community, to think through, how do we go about doing this work? It's one thing to identify the problem, but how are we systematically addressing the issues that come before us? Oftentimes, unfortunately, in your cases, it is the last-ditch effort. It's unfortunate that a lot of other systems have failed by the time someone comes before you in the courtroom. And so we don't want our courts, and we can't legislate good hearts, and we can't legislate good health. We have to work together on this. And so that is where the BCR process, the Building Community Resilience process, came together. It's the how. We understand that collaboration is something that's important, but it's the how, because it's so messy, and it can take so much more time than, say, a rocket docket. So when we work within community, we're bringing multiple sectors together to first create a shared understanding. What is the problem that we're trying to solve? Beyond the statistics, beyond the stories, how do you bring those two together and truly understand what is the community narrative? What is an ACE in your community? Beyond, say, the 10 classic ACEs. What is that experience? And through listening to that qualitative experience and narrative, we begin to pinpoint specific systems, and we can begin to understand what is our collective state of readiness. And when I say that, that's not to point fingers. It's to look at a true snapshot of how well we are doing. No blame, again, and no shame. Because I do believe that most of us come to work every day and we are truly trying to do the best that we can. But it's okay sometimes to say, uncle, that what we have in front of us is beyond what we are actually being funded to do. And so that's where these cross-sector partners come into play, where we help each other, where we reach each other, where we teach each other. What's really happening on the ground? What are the policies that are the barriers? What are the funding mechanisms that are falling just short? Or even oftentimes, what are those things that we're not tapping into? Because a lot of times, this isn't merely about the lack of funding. It's sometimes about the lack of awareness, about funding streams that are there, that resources that are sitting unused for whatever reason. But we don't know about those things until we all come to the table and actually talk about them. And most importantly is that community voice, because that community voice will tell you what's not working. We may have some blue ribbon, certified, evidence-based program that worked well in Chicago, but is doing very little for us in Waco. So I know that a lot of folks like to use the term evidence-based, and it may sound odd for a professor to say, that's one thing, but what about community evidence? What about what is going to work in your community versus what some hotshot professor tells you from out of town? Yeah, that's me included. So as I said, as you can probably understand in working with community and leaning into the community voice and not just the data, that equity, it's important. That where we start in Nacogdoches County is not going to be the same place that we start in Travis. That what folks need in Bastrop is going to be very different than what the folks need in Dallas. And that's tough. That's a challenge, because we love to have these one-size blanket statements of this is what we will do. Across the board, this is how we will fund per pupil. Well, $12 per child in Dallas County is going to go a lot differently than $12 per child in Hidalgo. And that's messy. Because that means that we actually have to sit down and think about what does that community need. That takes a lot more time. That takes a lot more thought. That takes compassion. And so that's what equity's got to do with it. It is about meeting your community where they are understanding those needs in order to bring them up and also put in place the things that are needed to bounce forward and thrive. So let's talk about those pair of ACEs. This is the part that I think is, for a mental health commission, is really important as a starting point. In your electronic packets, we actually have included our pair of ACEs worksheet, which is a front side that has the blank pair of ACEs, and the back side, which is also about resilience, which I'll talk about a little bit later. But it is a way for us to be in community and really let community tell us what's on the branches and the leaves of their tree, what's in the soil that's driving the outcomes. So when we have been trained to look at adverse childhood experiences in particular, there's this push to do a screening. But what are we going to do with these data? When we realize that perhaps a child that's in front of us or a parent that we're working with has a score of 6 ACEs, that just becomes another data point without really understanding the context. Did those ACEs happen 20 years ago? Or 20 minutes ago? Relevant. But also, what does that person have to draw upon to heal? Where can they go to prevent? And what is our ethical standard with regard to handling these data and responding to these data? So when I first introduced the pair of ACEs tree, it really became important to understand and use stories to help understand what's happening in our communities, what's happening to individuals. So if you are a judge and you have a child, a juvenile in front of you who is disrespectful, who doesn't want to look you in the eye, who is very agitated, I think most of you know this is probably not this child's best day if they're standing in front of you. And unfortunately, based on the statistics, it's not their first time in a courtroom. I would critically ask, why is this child a repeat offender? What went wrong? Where are the adults in the room? And as an adult, what is my responsibility? What is my ethical responsibility in responding to this situation in front of me? So when I see that agitated child, is it because, once again, they're in a room with authority figures who have never been figures to be trusted in their lives? Because the authority figures that they grew up with beat the hell out of them, or didn't feed them, or left them to take care of the 4 or 5 other siblings. Or perhaps this is a child with a learning disability that the authority figures in their school never recognized that they had a learning disability and instead labeled that child as being defiant. Or is it that this child has never had one caring adult in their lives? And we know from the literature that that's the one thing that can make a true difference for most of our children who are most vulnerable. Just one adult. So what is our responsibility when we are in these positions of authority? Is it to just treat the symptom that we see in front of us? Or is it to dig a little deeper, to go into the roots of the community that child is coming from? Now, I spoke about the education piece of this. So are you seeing trends coming into your courtroom of children coming from the same schools, with the same labels, with the same histories? Is that an education issue? Is that the fact that the educators are their number one mission is to teach, not to do therapy, not to do screening? And no one wants to take our teachers away from doing that. But what are we doing to support the teachers so that they can be successful in that job? What are we doing to have behavioral health support in the schools? Not only to support the students, because trust me, if you're a teacher, you need help too. Because unfortunately, many of the teachers that are in the classroom suffer the same ACEs that they're teaching to, they're teaching around, that they're trying to coalesce and get to sit down in a classroom. Think about that for a moment. I noticed inside the book that you have all received the NAMI statistic that shows that 3 million Texans live in counties that have no psychiatrist. Unfortunately, I have to be the bearer of bad news. That statistic can be repeated across the country. We have a national shortage of psychiatrists, particularly child psychiatrists. And of the 200 of the state's 254 counties, they have a mental health workforce shortage. Now, I'm not an economist, although I can play one when I'm at a podium. But I would say that if we are looking at a labor shortage in this country, if we're looking at opportunities where we can get people back to work, what if we incentivize training and paraprofessionals in mental health? Not only would this serve our communities, but if we're saying 200 out of the 254 counties in this state have a mental health worker shortage, that's a labor opportunity. Because then those 200 counties, there are people looking for work. There are people looking for training. So it's a problem that can be solved if we have the will, if we prioritize the mental health and well-being of our children first. Because if we take care of that child, that means that we're also taking care of that parent. If we're taking care of that parent, then we are improving that community. If we truly care about children's health, these are the tough things that we say we must do. There are a lot of other arguments that your state legislature seems to have prioritized over and above these types of rubber hits the road issues, particularly when it comes to employment. This is an economic issue, and it's a solvable one. Imagine if we actually trained up people to do the jobs that are needed in our community. That's in the roots, that's in the soil. Those are the types of policies, the types of advocacy that you have the power actually to influence. And that has nothing to do with party. It has everything to do with ethics, though. So let's take a look at the extent to which this is an issue in Texas. Also in your electronic packet, we have included some of our Pair of ACEs worksheets or data sheets that we prepare with the communities that we look at or we work with. And it gives you an opportunity to drill down at the county level how you stack up, whether that is nationally, across the state, or in your particular county and then neighboring counties. And what I think is really important for us to think about is not only the traditional categories of ACEs, but specifically, how does that stack up in your county? Because again, it doesn't matter what's happening in Hidalgo if it doesn't have any relevance in Houston. So being very specific to the issues that are within your community are very helpful. And so starting with the data is very important. And across Texas, the number one ACE, or average childhood experience, is parental divorce. 28%, almost 1 in 3 of your children are experiencing this. And some would say, well, of course, I mean, look at the national averages. But that does not mean it still does not affect our children, that it's not traumatic to our children. As adults, I think we've come to intellectualize and say, oh, well, yeah, everybody gets divorced. But it has impact on our children. It has meaning on our children. And the answer is not, making parents stay in unhealthy relationships. It is what is best for that child. The emotional abuse, which actually shouldn't be surprising when we're thinking about divorce as being the number one. Clearly, we have issues with regard to stability, emotional stability in households. But why is that? We also have as the number 3 ACE, household substance abuse. And while they're three separate statistics, they are all very much intertwined. Because again, going back to looking at the parental ACE score in this state, 55%. So I would say from this point on, we all have ACEs. Only that little sliver of the room might be 0 ACEs. So that means that we all are coming into our relationships, whether those are work relationships, whether those are personal relationships, with some baggage of trauma, whether that's resolved or unresolved. Which means then it's no surprise that you have parental divorce, emotional abuse, substance abuse. People are medicating themselves in record levels. And that was before COVID. And these numbers were before COVID. But we also know that abuse numbers have ticked up nationally. Domestic abuse, as well as child abuse, have ticked up nationally during COVID. And substance abuse has ticked up. Overdoses have continued. And did we talk about the loss, the death of a parent as being an ACE? When we see those numbers tick from the death from COVID, think about how many caregivers, whether those are parents, grandparents, aunties, that are gone. So while we can sit here and politicize COVID, there's a generation of children that have been impacted by this. And that is something that will come in front of your courtroom one way or the other. And so when we think about adversity and trauma, we have to be willing to lean into a very difficult truth about how we are not taking care of our children. We're the adults in the room, and we can do better. So when we look at what's in those roots, as I was saying, there are multiple things that go well beyond what are the 10 ACEs, what some call the social determinants of health. And I say some call the social determinants of health because I have a little bit of an issue with how we've used that body of science. We've used that body of science that speaks to environmental and community level issues and then try to pinpoint and solve those by treating people. So if people can't afford housing, then perhaps all they need is a financial literacy test or training. As if we can train people to live better on very little, while the market keeps churning. No. Social determinants are helpful, but we have to look at that through the lens of what is the system that's driving that outcome. So when we look at individuals that are unhoused, yes, they have an individual state of being homeless without a home. But what are we doing from a systems perspective to actually make housing affordable? To actually make wages keep up with what is the cost of living in a particular community? And you might be sitting here looking at me like, look, I can't solve housing. But you do when you're sending individuals to jail for crimes that they committed in pursuit of trying to keep themselves housed, fed, clothed. So all these issues that are in that soil, they do come to rest in front of you. And again, that robe, that power of authority that you have actually does have immense influence in the policy sphere. So when we talk about our work, we do look at this through the systems lens. We do look at what is driving the outcomes that we see. So this graphic here is an excerpt from a larger graphic that we've created to really look at community resilience. So community is that yellow piece there. And we look at 3 sectors, and this should probably be, particularly for this group, no surprise that what we look at those 3 sectors that actually drive the outcomes that we see in communities. And that's housing, that's public education, that's law enforcement and criminal justice. And so when we look at things like educational outcomes, yes, an educational outcome is something that is reflective of an individual's ability to learn and matriculate through a system. But it's also a performance indicator of our school systems. Again, going back to that definition of resilience, what are we doing to actually meet our students where they are and give them what they need? When we look at housing very much informs and influences the level of economic development in our communities, the level of access to capital, community financing, and it also, the value of properties very much influence or directly influence what's available in those schools to begin with. So it is no coincidence that when you have low-income housing, low-income individuals, concentrated poverty, you also have some of the most underperforming schools that we have across the nation. This isn't just Texas, this is across the nation. And again, when we have equal funding, so equality in funding, we set those children further back because we're not giving them what they need. We're giving them the same as everybody else. But they're not starting from the same place. And then let's be honest with ourselves. Low-income housing, concentrated poverty, underperforming schools. There's also a direct gradient to how we police in those neighborhoods. There's also a difference in how we police within those schools. And this is why I've talked across the country about our schools themselves being a pair of aces, an adverse childhood experience and an adverse community environment. I live in Washington, D.C. I moved there 10 years ago from Seattle, Washington. My kids were always in private schools. They were in Catholic schools before we moved to Washington, D.C. Then when we got to D.C., my son decided, Mom, I want to go to public school. I said, are you out of your mind? Why would you wait till we moved to Washington, D.C. to want to go to a public school? And he said, no, Mom, I want a more diverse experience. I said, no, there's no way. He says, no, Mom, come and visit Deal. So we live in upper northwest DC, and I went and I walked through Deal, and I was like, holy smokes, this is better than any of the Catholic schools either one of you kids went to. He goes, I told you, Mom, look, they have 100 clubs. Look, I can take Italian, blah, blah, blah. And I'm like, what in the world is going on here? How does DC fund its schools like this when I know nationally the numbers for some of these schools are not so hot? And then I met with the PTA. See, up in Upper Northwest, that's where you have the academics, you have individuals who work in federal government, who are embassy staff, and blah, 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 blah. So when DC Public Schools decided to do across-the-board cuts a few years ago, and what did our school do? So, okay, well, that means that the principal's going to have to make some very tough choices. The Italian teacher's going to have to go, and we're probably going to have to cut lacrosse. Yeah, and there are a couple other things. Well, the PTA was enraged. Oh, absolutely not. We will not stand for that. We're going to go to city council and demand our money back. Yeah, that's exactly what I did at the back of the room. I said, I don't think that's going to be a good look for us. And here's why. Because the cut at Bellew, east of the Anacostia, is a lot deeper than the cut we'll suffer up here in Upper Northwest. And I said, if we're going to go to city council, we should be there on behalf of those students. Because we're all in the same district, but those students only have a 55% graduation rate, whereas the school that my kid's feeding into has a 99% graduation rate and mandatory AP classes all the way through. That's a public school. That's the same district. I bring this up not because DC is different, it's because DC is the same, and we know it. So my son still graduated with 4 years of Italian under his belt, and he played lacrosse too. Because the PTA, we did a fundraiser, and we covered the salary for that Italian teacher, and we bought not only did we save the coach's job, we bought all new equipment for those kids. Yeah, I don't know if I want to take applause for that. Because when I think about what happened to the kids at Bellew, it's actually sickening. We're all in the same city. Our kids are rubbing shoulders. It's not fair. It's not equitable. And yet, it is de rigueur of life in the United States. Those are the systems that drive the outcomes, inequitably, intentionally, and reliably so. Nothing that the parents did at Deal was against the rules. But the parents at Bellew didn't break any rules, but their children suffered. Those are the types of policies that drive inequitable outcomes that we see across this state, across these United States. And that's the system. So when you have me come to the stage and talk about ethics, I'm going to ask you and I'm going to challenge you, what is ethical about that system that intentionally does harm to our children in an inequitable fashion? I want to drive home some of these data for you to consider. We talk about the burdens of inequity. When we talk about the numbers being right in front of us, the story being right in front of us every day. So child abuse. I pulled up some local data across the state, but I want you to see that these are not coincidences. These things co-occur, and reliably so. So when you see higher rates of child abuse, you also see higher concentrations of poverty. That is not something that is unique to Texas. That is something that is in the literature that we understand. But those two pieces there, abuse and poverty in itself is an adverse childhood experience, and we can unpack that for days, right? Because we understand that when you're growing up in poverty, that means you're also growing up with greater instability in the household, whether you're housed or not housed, whether you have food on the table. And again, remember what I just said, even the quality of your education, the quality of your care. If your parents are lucky enough to be able to work 2 jobs, that means somebody else is taking care of you, hopefully. But if you're at the poverty level, you're making some really tough decisions about who is caring for your child. Think about how many of those cases you've seen in the courtroom about child neglect, a child being left in unsafe conditions, a child being left to care for themselves. It's not always because mom is out partying, tripping the light fantastic, unless, of course, that's the light at Walmart, trying to put food on the table. So this is why we have to not just think about the treatment of mental health. It's about what are we doing to cure and enrich that soil in which the community is planted. And when we look at inequities with regard to criminal justice, I do want to point out that parental incarceration is a leading ace in our country. And many times that's not really stated. We talk about this being a country of law and order. We talk about this, the numbers of individuals that we have the highest rate of mass incarceration of all the developed countries in this world. But step back for a moment and think about how many parents are incarcerated. That changes the conversation a bit here. Because we're not just talking about adults making decisions or bad decisions for themselves. We're talking about some collateral damage here, and disproportionately so. So again, that child that I discussed earlier that was agitated in the courtroom, perhaps he was sitting on his mother's lap watching his own father being adjudicated and taken away. Perhaps that child really does understand the weight of being in front of a court, that weight of being judged. Because that moment that they're in front of you is probably not the first time that they've been judged. They've been judged because they're poor. They've been judged because they go to that school. they've been judged because they're hungry. Think about that. That's the burden of parental incarceration. It is a two-gen issue. And so when we think about the disproportionality of who is being incarcerated and for what, I would just ask, is it really worth it to ruin a child's life? Is this really the best that we can do? And when we talk about parental incarceration, I think the other part of this that we have to consider is, where do these children wind up? So again, focused on Bastrop, Bexar, Tarrant, Travis, and Victoria counties. Just look at those foster care numbers. As you can see, everyone is at a higher level than what they were 10 years ago. And this is at the time that we've had an opioid crisis, we've had COVID-19, we've had rising incarceration rates, we've had higher rates of community stress and related illnesses. All these things that when we talk about the number of adults that have been taken away, that means children have been left behind. And we do not have a foster care system that's ready for that. Never was. It was never intended to be a permanent fixture. It was supposed to be an emergency, for emergencies only. But now it's like every day we're on fire. Every day a child is being shipped back and forth. And that kind of instability is one of the ACEs that isn't even defined as one of the classic ACEs. I can't imagine something that's more devastating than not having your parents, knowing that you're in a foster care situation, and not knowing when it will end, not knowing if you'll ever have a forever home. So our decisions every day, while they may not seem like life and death, truly are, particularly if the consequence is that a child is going to be removed and put into this system that is itself not designed and not equipped for what is our reality. Now, that's not to say that we keep children in unsafe conditions, but would it be that difficult to actually think about how do we treat the child and the parent? Again, I think we can chew gum and walk at the same time. I think we can do that. We can find solutions where we actually work and with families to improve outcomes. Because what you're looking at there, not only is it not sustainable from an emotional and traumatic point of view from the children, we can't even afford it. Those are the challenges, one of the challenges that's in front of us. So when I use this tree in our work, I oftentimes, and when we use the data, I oftentimes remind our advocates, people who are working in the community, that it's not enough to have data if you don't have a story. And I'm going to tell you a story about Chloe. See, I have a very circuitous route to public health. My first career was actually in television news. And I used to tell a lot of stories about abuse and neglect. And that was one of the areas that I did a lot of volunteering in community gardening ad litem, Big Brothers, Big Sisters, because I could see, being a storyteller, how often our systems had failed our children and our families. And it was finally one story that took me over the edge. And I said, no, I can't do this anymore. I can't be one just pointing at the problems. I want to be a part of the solution. So I left, and I embarked on this career of public health. And I'm going to tell you the story of Chloe. So I was in Seattle, Washington, where Norm Mailing, the late Norm Mailing was the county prosecutor. And he had created a very innovative program. I say innovative, now it's not so much, but in the early 80s it was. And he said, oftentimes the parents that we are prosecuting that have drug offenses have ACEs. Now, this was very early on, at the very beginning of understanding what adverse childhood experiences were and understanding the connection to substance abuse. And what Mailing said was, sure, we can lock them up and throw away the key. But what about the children? And what about what's actually happened to that parent? What is it that they're medicating? When we take Tylenol, it's because we have a pain. When we use lidocaine, it's because the muscle aches a little bit. We know that, for the most part, people that are taking oxy, heroin, are not trying to get rid of a headache. It's a heartache. It's something that replays in the mind that they just can't get away from. And Mailing understood that. And so he said, you know what? So instead of automatically prosecuting these parents, what if I gave them an opportunity to seek treatment while at the same time recognizing that the child has also been traumatized because of their parents' substance abuse? So there's this organization called Child Haven that actually has therapeutic daycare. So we can put the children into an intensive therapeutic daycare. We can keep them on track for matriculating and developing in a healthy way. They embedded Head Start inside of this daycare center, so they would be kindergarten ready. They had trained psychologists who did what's called parent PNP. So it's working with parents to teach them what is positive play with your child and giving them supports so that when they felt like they were going to relapse, whoa, let's pull this back. Let's unpack this. Let's figure out other ways to deal with your trauma for the sake of the child. For the most part, Child Haven has a winning record. The programs, the children that they have been able to treat and work with, the children have much lower, in fact, 86% lower incidence of being involved in juvenile justice. 98% of those kids go on to graduate from high school. The parents remain the main custodial parent. And a 78% rate compared to their peers, 78% of those parents do not relapse into drug abuse. 10 years later, so a longitudinal study of these families that were able to go through the Child Haven program, 100% of those parents 10 years later have no public assistance, meaning that they are healthy, they are working, and most importantly, their children are productive. Except for one story, and that was Chloe. And that was the story that I got called into. So Chloe's mother had a long history of heroin use. And she was trying her best. She was coming in on a weekly basis. She was being tested. She was doing everything in the therapeutic sessions that was necessary, except that the therapists at Child Haven noticed that Chloe was becoming more withdrawn. A child that first started like this and then began to blossom was suddenly withdrawing again. Then they noticed bruises. And they said, okay, well, let's reach out to Child Protective Services because this is the protocol in this program. We reach out to CPS, and CPS can go and have an interview with the mom. They filed a report with CPS. And Chloe comes back and there's more bruises. So they talked to Seattle Police Department. Said, is it possible that someone can do a well check? I'm concerned because Chloe's also coming back after the weekends and she's extremely hungry. And we can't get her to sit still. And she was doing so well. And the mom, well, she's not necessarily coming to all of her appointments anymore. So we really have concerns. See, the folks at Child Haven were doing their job. They were working with their other partners, CPS, Seattle Police. They even reached out to the prosecutor's office, and everyone took the report diligently and said, yes, we'll be on this. And then one day, the Child Haven van comes to pick up Chloe, as they always do. And they knock on the door, and there's no answer. And they knock, and they knock, and they call. Because, see, the way that this program is set up, it's not an option that the child has a sick day. Someone has to put eyes on the child. So the Child Haven staff did what they were supposed to do. They were insistent. They did not leave. The mother came to the door and said, oh, she's not feeling well. She's not going to be coming to school. We have to put eyes on her. No, that's not possible. And then she changed her story and said, well, Chloe's not here. So Child Haven did exactly what they were supposed to do. They called the police. Oh, now the police responded, and they came. And they did a walkthrough. And initially, no one saw Chloe. There was no signs of Chloe. But the Child Haven van driver said, well, wait a minute, can I walk in? Because part of their job was to actually have eyes not only on the child, but also on the apartment that they were in to ensure that it was safe. And when they went into Chloe's room, they said, wait a minute, that's not where her bed normally is. Her furniture has been rearranged in this room. And the mother got very nervous. And the police officers asked the Child Haven person to step out of the room while they moved the bed, and that's where they found Chloe's body. She had been dead since Friday, since she came home from Child Haven. The staff was devastated because this was a child that they were invested in, and they had done everything right, except the systems failed. This death of this child actually led to a major investigation of the entire system because the number of repeated calls to CPS, the number of times that the red flags had been raised, and no one reacted. I'm sure that there are cases like that here in Texas. There are cases like that everywhere. Why? Why can't we do better? Especially when we put the systems in place, we put the rules in place. No one's making us do something that we didn't agree to. If you're CPS, you agree to child welfare. This is not only what collaboration is about, but it's also about accountability. And as the adults in the room, we do have to hold ourselves to a higher standard, and we have to hold ourselves to accountability if we're going to address what's in the soil. So, again, I appreciate you all putting me under ethics, because this is about ethics, ultimately. It's about compassion. It's about, as adults in the room, what are we actually doing to protect our children? Now, I've talked a lot about the work, but I also want you to be able to use this work in your practice, in your chambers. When you're looking at a case, what is really the problem? Not what is the offense, what is the charge? What is the problem here? Where are the disconnects? What are the strengths from a systems perspective that we can draw upon to not only resolve the charge, but to heal the problem? Who else needs to be at the table? What are the policies? What are the practices that are driving this? And what are the programs that we can be working with across different sectors? We're not getting paid by head, per head of the individuals that we see on a docket every day. That's not how this system works. So there really isn't a personal reward, at least I hope there isn't, for adjudication. What is the ethical thing to do to stem the tide, ultimately, of trauma? That's how we use the pair of ACEs in practice, to really lean into these very uncomfortable questions, but ultimately to get to community resilience. And I stress the community piece of this because I know I'm in Texas and we like to pull ourselves up from bootstraps here, but let's be real. Some folks don't even have the boots. And even if they did, where in the hell are they going to go without a system that actually supports, that actually is rooting for us collectively to succeed? So community resilience means that we actually are giving families the supports that they need, whether that's emotional, whether that's physical, whether that's a pathway to economic mobility, so that they can do better and so that their children can do better. And that means that we have trauma-informed supports that are in that soil that actually sprout those outcomes, whether that's integrated social services, reimagined public safety, supportive schools, the social and emotional support that actually goes into supporting social cohesion and also social capital. That's what community resilience looks like, not just about grit. It's about our responsibility to one another. Ultimately, it is about our ethics, and it's about our compassion. I have a feeling that all of you are here today because you have all of the above, that you did not come here because, I just want to be in Georgetown. And for those of you that are tuning in virtually, I have a feeling that you're spending this time away from doing anything else because you actually care, because you actually want to make a difference. Good. It's the first place to start. The other place to start is with courage. It is about courage. Ethics takes courage. Compassion takes courage and heart. And I believe that when each of you were sworn in, you were sworn in based on your ethics, but also your capability for compassion. That's what community resilience looks like. And I look forward to all that you all will do and continue to do to actually build resilience in your communities. Thank you.
Great job, Dr. Ellis. And I think we will take just a quick question for Dr. Ellis. Go ahead.
Dr. Ellis, the applause was in reaction to a couple of things that you said. Awareness, right at the beginning, and that's what we're out here for, and we continue to do, is to become aware through formal education, continuing legal education, or just being involved. The example that you gave concerning the PTA at Deal versus Blue. Now, Deal organized to make a change and to promote what their values were. They could have easily networked with Blue to encourage them to do the same thing. So I think that we have responsibility to network and to be the commanders or the champions of our own destiny and those things that we wish to do. And in a small way, when we make that effort to be able to connect, we are being ethical, being compassionate. But people have a responsibility as well to educate themselves. Mm-hmm. The little small thing that I do from the bench is when I have an offender, defendant, about to be sentenced, and I find out that they have children, I ask the ages of the children, and I usually order parenting class. Some attorneys question that, some folks question that. Why are you ordering parenting class? I state this, because that parent needs to understand how valuable they are to their children. Not because they needed to know how to change diapers or anything like that, but they need to be reminded that they're valuable to their children and ultimately their community. My question to you is, how do we continue to promote such responsibilities throughout the community? Thank you very much for your study. I love that pair of ACEs. It is phenomenal. Both adverse childhood experiences and adverse community environment. You just hit it on the head. Thank you so much.
Thank you. What is your name? I'm sorry, I didn't get.
Oh, you really haven't guessed yet? It's Grace Uzomba. I'm from Bexar County.
Thank you. I really appreciate, and I appreciate the fact that you're bringing up value here, because that is so key for many of the defendants that you see. If you actually said what you said to me about you have value, oftentimes that is the first time that these individuals have even been told that. And so they don't even recognize that they have value to others because no one's ever valued them. And so that in itself is so incredibly powerful. And I would love to be able to encourage those who are working with these populations. It's starting from that simple place. It's like we all have value, regardless of what you may have done in the past or what you may do future. You have value, and you have value to someone, not just to yourself, but to someone. That changes the paradigm in relationships completely. Now, when you were talking about the individual responsibility, the deal, I tell the Deal story not to brag about my community at Deal, because I'm actually embarrassed by that. I'm embarrassed by the fact that here we were well-to-do parents that could not see that what was going to hurt, and I use air quotes, hurt our children, we easily had a solution for. And the automatic response is, I'm going to fight for what we have without taking consideration of what others don't have to begin with. What I had actually advocated for and was shot down was like, well, if we're going to write checks for the Italian teacher and for the lacrosse teacher, can I at least show you all some of what is the reality at Bellew High School? Here's the reality. Here are the numbers. We have in DCPS the ability for students to be able to apply to go to different schools from across the district. There are certain slots that are left. There are students that actually were in the Bellew catchment area that were coming all the way up to Wilson and Dill High School and middle school because they wanted to escape Bellew, which was their school. And I said, has anyone even talked to any of those kids to really understand why it is that they're making a lot of times an hour and a half commute on Metro to get up to Upper Northwest? No, I don't even know if my kid is in the class with their kid. Of course they are. We're not that different. But what, from a responsibility and education point of view, I felt like, well, let's do a fundraiser for Bellew. Why don't we do something to materially contribute to the kids that are our kids' peers? They may not be in the same school. They may not be in the same district. Well, they are in the same district. But ultimately, this is our community. And that piece of it, I think, we have done a good job. We have silos that are our sectors, but we also have silos that are our communities and our identities. And we don't have a sense of collective responsibility, which I find to be so against what is truly supposed to be about America. Aren't we supposed to care about each other? What is so hard about that? And why is that such a difficult conversation? If, again, thank you for putting me under ethics, if it's about ethics and compassion, what's wrong with that? That's the piece of it. It's not about responsibility so much for Bellew. Those parents are doing a lot with so little. It's about what is my responsibility to look outside of myself and see what can I give. Why does it have to always be about me? That's, I think, where we are, and that's why we're where we are as a country, the failure to be able to do that. Thank you.
So, Dr. Ellis, are you going to be sticking around a bit?
I have some time.
Okay, great. Because, of course, we would love to have more questions, but we are running a little behind, and I know we're up for our next break. So if anyone wants to speak with Dr. Ellis, please, you can do so during the break. She will be sticking around for a few before she heads back to Washington, correct? DC. So again, another round of applause for Dr. Ellis. It was a very, very great presentation. Extremely impactful. Thank you.